Good evening, respected Professor Nakasami sir and Professor Vasanthi madam. And I welcome you all students, dear students, for this wonderful session or research anesthesia online academic activities, DNB academic activities. Today we have a very interesting and important session on a case discussion involving a pregnant woman with mitral stenosis, along with obesity and diabetes mellitus. So can we start the session, sir?
Yeah, before we can go ahead and Arun can start, this is not the same complications in a one single woman. Okay, this is probably a topic with requires a little bit of lateral thinking. It is not straightforwardly given in any textbooks if you see. So each condition is a little different. So I'll start with a question to Arun. Under
Yes,
what group you will, good evening. Under what group you will classify all these things? Today we have three complications occurring in a patient, isn't it? One is mitral stenosis, or we can say valvular diseases. Then is the obesity problem. Third is the diabetes mellitus. So under what group you can club them together?
The high risk pregnancy, sir.
High risk pregnancy is one, but high risk pregnancy is usually related to pregnancy related, like severe preeclampsia or HELP syndrome or something, or a very, very elderly preemie and all that. But
high risk anesthesia complicating pregnancy.
There is one terminology given in the FRCA textbook, which is called medical diseases complicating pregnancy. So if you go ahead and see the FRCA podcast book, there is one topic called medical diseases complicating pregnancy. Okay. So all these three conditions can be clubbed under that particular category, because in a normal healthy woman who becomes pregnant and progresses on to the final term and delivers, everything goes on well. There is no cardiovascular system issue. There is no diabetic issue. There is, unless she has been obese prior to gestation, there is no problem, all that. And if you say problems per se to the pregnancy, it can be only preeclampsia, eclampsia, and HELP syndrome. And gestational diabetes also has been added of late to that particular category. But obesity and valvular diseases, all these things are individual conditions which may be present there in a pregnancy. But it is not induced by pregnancy by itself, except the gestational diabetes, which can be a part of complication induced by pregnancy itself. So I thought it will be ideal to say that it is all medical diseases complicating pregnancy, number one. The second question is, do you find any of these three conditions which can occur simultaneously in a patient? Of the three conditions which we are now going to discuss, like valvular diseases or mitral stenosis, obesity, and diabetes, could any two become a component in a single individual?
Yes, sir. Obesity and diabetes mellitus can go together.
Very good. So it can be either obesity patients are likely to have associated diabetes and hypertension, and the diabetes could have happened in an obese patient by itself. So those two things can be clubbed together or present in the same individual. That possibility is there. Okay. And another important thing, third point, what I thought was, we have generally said that pregnancy complicated by valvular disease or mitral stenosis, obesity, or diabetes. So how can you classify them in a pregnancy? I think my question is, that's why I think my question is not very clear. So I will rather put it this way. We can say that some complications can be present even before the woman becomes pregnant. For example, a mitral stenosis could have happened well before she got married and she got pregnant, and then it exhibited only during pregnancy. That possibility is always there. Similarly, a patient could have, nowadays, ladies are getting married very late in their life and getting pregnant. Even at the age of 39, 40, they become pregnant for the first time. Before that time, they could have developed diabetes. So pre-gestational diabetes could have been there, which could have been detected only during the gestational period. Okay, and wrongly branded as gestation-induced or gestational diabetes mellitus. That is a second possibility. And obesity, of course, it is a natural thing which could have been there even before pregnancy. But mostly we have to discuss how it will more complicate the pregnancy, induce normal physiological changes. That is, from that angle only, obesity we have to discuss. So these are all the things what I thought about today's presentation. Let me see how you are going to present about it.
Sir, can I add one more thing, sir?
Sure, please.
Sir, obesity treatment methotrexate is used, sir. That can cause mitral stenosis.
Obesity?
Methotrexate therapy. Treatment with methotrexate.
Okay. But how I don't know whether these drugs therapy or pharmacological treatment for obesity is
Nowadays, they are not.
yeah.
That's more than a decade old point.
Yeah,
Sir.
yeah. Even the sibutramine and other drugs are not commonly prescribed by endocrinologists or physicians or nutritionists. So either they go for exercise and diet or straight away advise bariatric after putting them on liquid diet for 2 to 3 months and trying to see whether they can stick to that diet and then plan for a sleeve resection or some bariatric procedure.
Yes, and definitely not in a pregnant person.
Pregnant,
Yeah.
Okay.
Obesity and that will never come together with that.
Yeah. Okay, right. Arun, with this introduction,
Yes.
I think you can go ahead and make your presentation.
I'll start, sir.
Hmm.
Malavika, 29 years, female, coming from Villivakam, Chennai. Husband working in railway hospital, presenting with complaints of missed period for 9 months and shortness of breath for 3 months. History of presenting illness, primary gravida with last menstrual period on 17/5/21 and expected date of delivery is 23/2/22. Gestational period roughly around 9 months to 3 days. Breathlessness gradually progressive, exertional, not seasonal, belongs to New York Heart Association class 3. Antenatal history, first trimester, it's registered on antenatal clinic at a private hospital, started on iron and folic acid, had history of mild exertional dyspnea, no history of vomiting or any other significant illness. Associated with intermittent cough, no history of fever, no history of chest pain, no history of syncope, no history of swelling in both legs or neurological deficit. In second trimester, quickening is felt at 5th month. 2 doses of tetanus toxoid has been administered. First visit in railway hospital at 21 weeks of gestation, and she was diagnosed with gestational diabetes mellitus and was advised on diet. No further visits or complaints in the second trimester. Third trimester, dyspnea progressively increased from class 2 to class 3. She was admitted in ward 3 days ago and advised fetal monitoring and further investigations and management. No history of bleeding PV. Past history, she had history of fever with joint pain at the age of 5 years and was diagnosed to have mitral stenosis at the age of 15 years of age. No other significant past history. Treatment history, she had taken prophylactic benzathine penicillin, but was irregular on taking this injection, and it was started at the age of 15. Marital history, married to 2 years ago, non-consanguineous marriage. Menstrual history, her menstrual periods were regular, normal flow, no clots, and 3 to 5 pads per 30 days. Personal history, normal bowel and bladder habits, no addiction, housewife by occupation, no history of snoring, and her sleep pattern was normal. General examination, her height is 165 centimeter and weight is 86 kilos, and her BMI is 31 kg per meter square. She's afebrile. There is no pallor, no icterus, no cyanosis, no clubbing, no significant lymphadenopathy in any regions. Bilateral pitting pedal edema, grade 2. Neck veins are not engorged. Pulse 107 per minute. Regular. Low volume. Felt in all peripheral vessels. I mean, all peripheral pulses felt. BP is, blood pressure is 107/52 in left arm in supine position. No signs of any bleeding manifestations. Coming to the systemic examination, respiratory system, respiratory rate is 18 per minute, bilateral air entry present equally, normal vesicular breath sounds heard. Cardiovascular system, inspection, there is no obvious deformity, no visible pulsations. Palpation, apex beat at left fifth intercostal space, half inch inside the left mid-clavicular line, tapping in character, diastolic thrill palpable in the mitral area, which is best felt in the left lateral portion at the end of the expiration. And auscultation, S1 is short and sharp, accentuated, S2 is audible, P2 is loud in pulmonary area, opening snap not heard, low-pitched mid-diastolic rumbling murmur with pre-systolic accentuation is present in the mitral area without any radiation, best heard with the bell of the stethoscope in the left lateral portion at the end of expiration. Moving on to the abdominal system, inspection, abdomen distended, umbilicus inverted, stria gravidarum present, palpation, the fundal height corresponds to 32 weeks, vertex presentation, no epigastric tenderness, auscultation of the fetal heart sounds 152 per minute. Moving on to the central nervous system, she is conscious, oriented to time, place and person. Motor function, tone, deep tendon reflexes are normal. Sensory function is also normal. There is no obvious focal neurological deficit. All cranial nerves are normal. Airway examination, mouth opening is 3 fingers breadth present. Mallampati grading is 2. Thyromental distance is less than 6.5 centimeter. Sternomental distance 11 centimeter. Neck movements are terminally restricted. Short neck. Temporomandibular joint is mobile, and there is no artificial teeth or dentures or no loose tooth. Spine examination, mild lordosis present. There is no obvious presacral edema present. Able to feel the spinous process normally. So provisional diagnosis, 29 years old primey, 36 weeks of gestation, gestational diabetes mellitus on diet with grade 1 obesity with moderate mitral stenosis, plan for elective cesarean section.
Okay. Now, so you combined the two problems in the same case, or probably the patient has both the cardiovascular problem as well as the metabolic problem of diabetes in this patient. Okay. So how did they diagnose gestational diabetes in this case? Which particular trimester or the weeks of pregnancy it was diagnosed?
It was in the second trimester, sir.
Second trimester. Okay. So how to differentiate between a pre-gestational diabetes mellitus and a classical gestational diabetes mellitus?
Pre-gestational, by doing a HbA1c, sir, glycosylated hemo, which tells you about the patient's blood sugar status 3 months prior to the diagnosis.
Okay.
By investigation.
Supposing patient has been a diabetic, you say she is 29 years old, she has been harboring a diabetes before pregnancy, she did not know. How do you find out whether it has been there even before pregnancy? Will HbA1c be able to give you a correct idea about the presence of the diabetes pre-gestationally?
HbA1c tells us only about the 3 months status prior to the.
Yeah. So the first trimester, if the blood sugar values are high, first thing is you have to take a random blood sugar and see the value. Okay. If the blood sugar is random blood sugar is more than, what is the accepted level in a pregnant woman?
Random blood sugar of more than 200 would be indicative of.
That is for everybody. That is not for pregnancy. The values are very, very low. What is the fasting accepted? What is the 1 hour or 2 hour postprandial accepted?
110,
Random is only less than 140 and fasting is 90. 1 hour postprandial is 120.
126.
120. Okay, these are the three values that are accepted. But on the very first visit during the first trimester, if she has a blood sugar of 180 or 200, then definitely you have to think of this as a pre-gestational diabetes. Whereas in the first trimester, values are all acceptable, 90, 84, 110, like that. But after 24 weeks, if it goes to 180, 200, then that is the one which you have to brand as gestational diabetes. So this distinction is very important. And you have concentrated mainly on the cardiovascular problem in examining her and getting the history and all that. Whenever a patient has a gestational diabetes, all the problems that due to gestational diabetes also should have been questioned from the history, and also you must examine them. So it is just like any diabetes complication that can happen in a pregnancy also. Okay. So what is the most important thing that you will ask in a diabetic patient? Which system?
Signs of autonomic dysfunction.
Autonomic neuropathy or autonomic dysfunction. That is the most important thing that we have to rule out in all these things. Second thing,
renal issues like how frequent they pass urine.
nephropathy. Okay. So how to differentiate between a nephropathy which has been there prior to pregnancy and occurring during pregnancy? Is there any testing or any difference? Supposing
Yes,
what is the pregnancy related complication that can happen because of diabetes?
Chances of preeclampsia.
Preeclampsia, very good. So patient can have preeclampsia following diabetes also. So how to differentiate between renal involvement because of preeclampsia and renal involvement because of diabetes?
There will be an elevated serum creatinine levels if it's going to be a renal dysfunction causing
protein creatinine ratio and albumin creatinine ratio. These are the two things. If it is a nephropathy, you have to look for albumin creatinine ratio. Whereas if it is a preeclampsia, you go for protein creatinine ratio. These are the two things which will tell you or differentiate between a nephropathy because of diabetes, or that is if it the albumin protein creatinine ratio have been quite high, it could be a diabetic nephropathy which had been there for quite some time. On the contrary, if it is a purely protein creatinine ratio rise, it is a preeclampsia induced nephropathy. Okay, so that difference also will tell you whether the patient can go in for any acute complications in this or not, right? And then now coming to, so that with regard to the maternal and fetal complications in diabetes, what are all the questions or history you could have elicited?
the chances of difficult airway is both for obesity as well as for diabetes patients because stiff joints.
Now we have not included obesity in this case. Now you have presented only mainly the case of diabetes with associated with valvular mitral stenosis. Okay, so we will stick to that. We will discuss obesity later. So with regard to obesity, what are all the questions to the mother you could have asked? Keeping in mind the complications that can be happening in the maternal as well as in the fetal system. So if you would club it in these two categories, then you will be able to ask the history with regard to these things.
Obesity related, sir?
No. Diabetes related. Now your case is only mainly diabetes and the valvular diseases. I'm not going to include the obesity here at all. Obesity we will discuss separately, because you have not mentioned anything about obesity here in this case. Whether the patient had a very high BMI or anything, you never mentioned. So we will keep
And
that
usually,
as a,
usually, sir, when a mitral is there, I'm sure they cannot be obese also. It'll never be there. It'll always be, it'll always be, they'll all be very thin. So maybe, diabetes and mitral, I think we will stick to that.
So any complication which is common in a diabetic patient is common in a pregnant diabetic lady also. Okay. So what are all the questions that you would like to ask in a pregnancy? I mean, forget about pregnancy. What questions you would like to ask in a diabetic patient from history?
The signs of autonomic dysfunction like
Okay.
gastroparesis.
Okay. Would you like to ask something about the treatment history, whether they have had any hyper or hypo spells, whether any history of diabetic ketoacidosis? Okay. So what is the difference in the ketoacidosis between a non-diabetic, I mean a diabetic woman who is non-pregnant and a pregnant woman? Is there any difference in the ketoacidosis that is likely to happen? Supposing this woman has been a diabetic even before pregnancy and she develops ketoacidosis, what will be the nature of that ketoacidosis? Whereas after pregnancy, say 7th month, 8th month, she develops ketoacidosis. Is there any difference between these two?
The pre-gestational diabetes patients, they have more chances of landing up with the DK rather than these gestational diabetes patients. They have the high chances of non-ketotic hyperosmolar.
No, both have ketone positive and blood ketones are also high. But what will be the major difference between the two? The pre-pregnant patient will have hyperglycemic ketoacidosis, whereas a pregnant woman majority of the times develop euglycemic ketoacidosis. So it is very, very difficult to diagnose ketoacidosis when it happens in a pregnancy lady, especially in the advanced stages, because blood sugar values may misleadingly be normal or very slightly raised. So you have to suspect ketoacidosis with regard to the other features like drowsiness, smell, and ketones present in the urine. Like that only you have to. So euglycemic ketoacidosis is very common in the pregnant woman, whereas hyperglycemic ketoacidosis is very common in the non-pregnant diabetic woman. Okay, so that is a very, very important difference that you have to remember between these two pathologies that is happening. Right. And with regard to the fetal,
one minute.
yeah.
So 1 minute. So I think that's where they always keep saying that we have to do the ketone body levels and the urine in these patients who are suspected to have diabetes.
Diabetes,
in spite of doing the blood sugar level.
Blood sugar, yeah. And another important thing is the frequency of blood sugar testing. Yes, that is another question that should have been asked whenever a patient gives history of having been diagnosed with diabetes. Okay, so there are two methods of testing. What are the two methods of blood sugar testing?
Fasting blood sugar and postprandial blood sugar, which is done after 2 hours of 75 grams of anhydrous glucose.
Okay, very good. That is a glucose tolerance test, GTT. But in a routine fashion, what are all the techniques of testing for blood sugar?
We have venous blood sugar testing, capillary.
That's self-testing or self-monitoring of blood glucose and hospital-based or lab-based monitoring of blood glucose. These are the two things. Whenever the blood sugar values are over 200, it is better that the patient always comes to the hospital and gets the blood sugar tested. Whereas if it is less than 200, the patient can have the blood sugar tested at home with the glucometer or with the capillary blood. Once first in the morning as a fasting and then another 3 readings 1.5 hours after every meal. So totally 4 times they have to get the self-monitoring of blood glucose. That is what is recommended by WHO in any pregnant woman. Whereas if the values are more than 200 right from the time of testing until they come down to less than 140 postprandial with treatment, they have to have lab-based or hospital-based testing to avoid the problem of the complications, right? So this is another important point which is not given in the regular textbooks, but more given in the obstetric textbooks from which I picked up this information. Okay, so that
So
is
it also
another.
says.
Hmm.
So it also says not to do just the CBG, but always do the blood sugar levels. No, sir.
Yeah, for self-monitoring, for on a regular basis, you can do the CBG itself at home. So
No, sir. In the labs.
the lab, you have to go for plasma glucose. Now, more than whole blood glucose, plasma glucose gives the correct value. Okay?
Yes.
So you have to go for plasma glucose only, right? So, and with these are the problems with regard to mother, with regard to the presence of diabetic nephropathy. And supposing the patient has been a diabetic prior to pregnancy, what will be the mode of treatment and what will be the mode of treatment after pregnancy?
If the patient is on oral hypoglycemic agents, that is for a pre-gestational diabetes patient, probably we have to switch over to
Not
insulin
probably,
therapy.
you must switch over. Why? Why? What is the reason?
To have a better glycemic control, as well as to eliminate the side effects of the oral hypoglycemic agents.
Main side effect is it will cross the placenta and cause fetal
and affect the
anomalies.
fetus.
Okay, so if a lady has been a diabetic prior to pregnancy and they have been managed with oral hypoglycemic agents like your sulfonylureas or dipeptidyl peptidase inhibitors or your acarbose and other, all the oral drugs except 2 drugs should be stopped. Which are the 2 drugs which are permitted even if it is pregnancy or gestational diabetes?
Metformin, sir.
Metformin is one, very good. Then only one sulfonylurea is permitted. What is that sulfonylurea?
Glibenclamide.
No. Glyburide, Glyburide. Okay, these are the only 2 oral hypoglycemic agents which are permitted to be administered right from the first trimester, because they don't cross the placental barrier and they don't cause any fetal anomalies. That is why anybody who has had diabetes prior to pregnancy should be converted to insulin therapy, or the only 2 drugs orally which can use is metformin. Even though metformin also crosses the placental barrier, but extensive studies have shown that it doesn't cause any fetal anomaly or fetal malformations. Okay, so up to 2,500 milligrams per day can be given for control, but majority of the times it is better to go for insulin therapy only. So coming to the insulin therapy, what are all the methods of insulin administration in pregnancy? Especially when you need a tight control.
Ultra short acting insulins like Atrapid.
That has to be given as whenever you hear the word tight control, what will you think of?
Regular insulin, sir.
Not the type of insulin, but the mode of administration. That only will be deciding what is a tight control and what is a little lax control.
As an infusion, sir.
Yes. What are the types of infusions you can think of if that lady needs a tight control?
Ideal is to maintain the blood sugars around 100 milligrams per deciliter.
No. What are the names of the infusion techniques? That is the question. What is VRRI and what is SCII? I'll give you the acronym. You have to expand it. VRRI. Variable rate insulin infusion. VRII. What is SCII?
Subcutaneous, sir.
Subcutaneous continuous infusion of insulin. It is not only just subcutaneous continuous insulin infusion. Okay, so these are the 2 techniques or modes of administration of insulin for which you can use regular insulin or other, even basal insulin has to be given. There also there is a difference. If the patient is a known diabetic becoming pregnant, they have to have a basal insulin also along with the insulin need bolus insulin for control of blood sugar. Okay, so these are all the points that you could have been asked with regard to the diabetes patient as far as the maternal side is concerned. Coming to the fetal complications, what questions you could have asked?
Any previous, I mean, she is a primary, sir. So previous.
Previous question doesn't arise here because she's a primary.
Previous overweight babies, any history of polyhydramnias in case if she is a multigravida.
Being a primary, you can ask, are you feeling anybody told you that your abdomen is too big for your months of pregnancy or period of gestation, isn't it? Macrosomia is very, very common. Okay, so all the even household ladies would have commented, your stomach is looking too big for you say only 6 months, but it is looking like, are you having twins? Are you having any other problem? Go check with the doctor. So polyhydramnias or macrosomia, all these things can produce abnormally more girth or the more size of the abdomen, which could have been noticed. And that question, unless you ask, they won't know. Being a primary, she won't know. She may be thinking it's normal. So you can ask anybody commented about the size, that it's looking very abnormal, right? And whether are you feeling the fetal movements properly? Because IUGR and retardation of growth and fetal anomalies are quite common, isn't it? So the mother should be asked about fetal movements, whether anybody are you any testing has been done, anomaly scan, was it normal? All those questions could be asked to find out the fetal problem. Okay, right. So we'll come to the discussion of this abnormal size of the baby. What are the complications that can happen because of the macrosomia? And why does macrosomia happen, first of all?
Because of the increased insulin-derived growth factor.
Insulin-derived?
IGF-1, sir.
IV?
IGF-1, production of IGF-1 is very high in these, which stimulates the growth of baby.
See, more of glucose is coming. If the mother's blood sugar values are uncontrolled, if the blood sugar values are very high, automatically because of the concentration gradient, it is going to enter the fetal circulation, and fetus is going to utilize all the glucose that is coming there. So two complications will happen. Because of the increased utilization, the growth is more. So babies become big. But during the end of the pregnancy, what problem can happen because of the constant high glucose in the fetal circulation?
Sudden hypoglycemia after delivery.
Post-delivery, yeah, neonatal hypoglycemia is a very, very important complication that can happen because of the increased stimulation of insulin production in the fetus. Okay, so that is another problem that you have to keep in mind and ask the mother. Now, coming to the pathophysiology of the gestational diabetes occurring in a pregnant woman, what is the reason or what is the cause? How does it happen?
The placenta secretes insulinase, which degrades the insulin.
First of all, will the mother have a high glucose tendency always, even if she is normal and non-diabetic patient? Even though we say only 90 fasting is ideal and 110 or 120 1 hour later is ideal, will the mother have a tendency to have a high blood sugar level? Because she has to feed the baby, she has to nurture the baby in the womb, isn't it? So nature makes it necessary that she should have a high blood sugar level. And how that this high blood sugar level will happen? What is the mechanism? Is she going to eat more or is it going to be endogenously produced?
The presence of progesterone itself, it's a
liver has to supply. See, glucose, excess glucose release occurs from the liver to maintain the blood sugar value in the mother as well as in the fetus. Okay, so this causes excess stimulation of insulin in the mother also initially. But there are counter-regulatory hormones produced in the mother to nullify the action of the extra insulin that is produced. Okay. So when you come to pathophysiology, there is an increased production of glucose. In a normal healthy human, there is an increased production of insulin to utilize that glucose, so blood sugar values remain normal. On the contrary, in a pathological case where the mother is likely to become a gestational diabetic mother, there is an increased insulin production, increased glucose level, increased insulin production, but the insulin is not allowed to act to the utilize that glucose by three hormones. Which three hormones act as a counter-regulatory hormone?
Glucagon.
Yeah. Glucagon is not the hormone to produce this in the diabetes state. Normally, the four glucoses, 2 C's and 2 G's, that they are counter-regulatory. Cortisol, catecholamine, glucagon, and growth hormone. These four are considered as counter-regulatory in a normal, healthy person, whether they are male or female or in control of sugar. But in pregnant women, the pathophysiology to produce gestational diabetes, all these four hormones which are normally there, are they the ones which are responsible?
No, sir. Progesterone, sir.
Progesterone, growth hormone, and human placental lactogen. These are the three hormones which counteract the used. So that is a very important pathological difference. So growth hormone, human placental lactogen, and the progesterone, all the three nullify or try to act against a counter-regulatory hormone for insulin. Okay, that is a very important pathology that you have to remember. So that is why the blood sugar levels go up because of insulin resistance. And but the glucose level is transferred to the fetus, which goes there, causes more utilization, extra growth, and then stimulates the pancreas in the fetus also to produce a higher level to utilize that. But ultimately, after delivery, this production of insulin continues, which can result in neonatal hypoglycemia. Okay, that is how the entire pathology you have to remember. Okay, right. So all these questions can be asked with regard to the diabetic state. Okay, and coming to the cardiovascular problem, you have said about the occurrence of knee pain and fever, all these things happening at a very young age, diagnosed as rheumatic fever, advised penicillin prophylaxis not taken properly. Now, questions can be asked in the examination because mitral stenosis complicating pregnancy cases can be kept in the examination. So, the questions can be initially all about mitral stenosis and then switch on to the involvement of, the physiological changes in pregnancy, how they can exacerbate the problems of mitral stenosis. That is how the usual questioning will be done. Okay. So coming to, we will not discuss too much in detail about the mitral stenosis because that is not our case per se here. So how will you compare, associate all the physiological changes with mitral stenosis and how it can worsen the condition? The normal cardiovascular, hematological, and other changes, renal changes, everything, how it can especially affect the mitral stenosis, which is a left heart obstruction. Okay.
So pregnancy per se is a hyperdynamic state. So there is an increase in the heart rate of 15 to 20%, which is going to worsen the mitral stenosis by reducing the diastole period. So it is going to increase the gradient and it's going to worsen the symptoms. Then there is an increase in the blood volume of 40 to 45%, which is going to cause an overload state, and the chances of pulmonary edema is very high, and especially immediate delivery, where the chances of auto transfusion and all those things can worsen the problem. Then this physiological anemia of pregnancy can also increase the oxygen demand, increase the heart rate, and which can also reduce the diastole time and aggravate the condition.
Mm. You said the pulse rate was 107 and regular.
Yes, sir.
Should you have asked anything else about it? Especially when you say patient has been having dyspnea, even with mild exertion, isn't it? That's also part of your history, isn't it? I heard you correct.
Yes, sir. Yes.
So if a patient is breathless, even on mild exertion, and has a pulse rate of 107, could any other history could have been asked to this patient?
Palpitations.
Palpitation, yes. Whether she had any features of atrial fibrillation earlier, okay? So if it has been atrial fibrillation, if it has been diagnosed earlier, what would have been, how would you know that it has been there and corrected?
There will be any history of anticoagulants being prescribed?
Very good, excellent. Okay. So if the patient, which anticoagulant is safe in pregnancy?
Unfractionated heparin, sir.
All the time?
That is from 12 weeks to, the initial before organogenesis, that is till 12 weeks, patient can be on unfractionated heparin. Then they can switch over to, after 12 weeks, once the organogenesis period is over, then we can switch over to warfarin till 36 weeks. Then near delivery, once again, it has to be switched over to unfractionated heparin. Low molecular weight heparin can also be used. And in some centers, they use even warfarin right throughout the pregnancy with
Very low
lesser dose of 5 mg per 5 mg.
Okay, that is in case if you suspect thrombus, left atrial thrombus, or the possibility of a thromboembolism. Supposing there is no LA thrombus as per the echo study, but patient had on and off irregularity which was suspected to be atrial fibrillation, then how it could have been treated?
Based on
normally, what is the oral treatment for atrial fibrillation?
Sir, I couldn't get, sir.
Now, what is the normal pharmacological treatment you will give for atrial fibrillation?
Based on whether the patient is hemodynamically stable or unstable. Okay. If the patient is hemodynamically unstable, then direct cardioversion.
That we are not talking about an unstable patient. We are talking about a very stable patient who has on and off atrial fibrillation with
what drug can you give? That's all he wants.
Either we can go for rate control with the beta blocker. Then we can use verapamil.
Verapamil or diltiazem, which is safer?
Diltiazem.
The question is mainly to bring out that answer. Rate control with metoprolol, propranolol, or diltiazem are all safe because they don't cross the placental barrier. Can you use amiodarone?
Amiodarone causes fetal hypothyroidism.
So that is the point that your take-home message is not to use amiodarone for control of atrial fibrillation in a pregnant woman. You have to go only for either metoprolol or propranolol or your diltiazem. These are the three safe drugs which to control the heart rate in pregnancy. Okay, that is the catch question there. Otherwise, a normal non-pregnant patient, you would have first preferred to go for amiodarone, not beta blockers, isn't it? So that is the point that you have to remember with regard to the arrhythmias. So prevention of arrhythmia is very, very important in a pregnant lady, especially with mitral stenosis. So what will happen if the patient has atrial fibrillation during pregnancy with a mitral stenosis?
Because of since there is a gradient between the left atrium and the left ventricle, the output of the left ventricle depends predominantly on the left atrial kick. So if the left atrium is not, because of the atrial fibrillation, that contractility won't be uniform. So the cardiac output will be very less from left ventricle.
So are you worried about that or something else?
And also chances of thromboembolism is very high with atrial fibrillation. So.
More than that, any acute problem?
Flash pulmonary edema.
That is the most important thing. See, whenever a patient goes into atrial fibrillation with severe mitral stenosis and pregnancy with a volume overload, they can anytime land up with the pulmonary edema. Okay, so that is the very life-threatening problem that you have to be worried about more than thrombus or reduced left ventricular output and all these things. Okay, so always try to correct it as early as possible to prevent a pulmonary edema occurring in a patient. Okay, right. So these are the points that you have to remember. Now coming to having had an overall idea about the pathophysiology. Now if this patient requires assisted vaginal delivery or a cesarean section operative delivery, how are you going to manage? What is the anesthetic challenges that you are going to face?
If the obstetrician is willing for, is planning for a vaginal delivery, I'll first make sure that the patient is not on oral anticoagulants. If a patient was on unfractionated heparin, I'll make sure that it is stopped 6 hours before the start of the labor. And to see our previous records, echo, and classify whether it's mild, moderate, or severe mitral stenosis. And based on that requirements, based on the severity, I'll plan for an epidural analgesia to nullify the harmful effects.
Are there any guidelines how to manage the first stage of labor, second stage of labor, and third stage of labor? If you have read about that, it will be easy to say how to manage these cases, whether it is mild, moderate, or severe, whatever be the grading. How to manage the first stage, how to manage the second stage, how to manage the third stage. Being a primate, you have to go in relation with your case. Your patient is a primate. Will she have a prolonged first stage or a very short first stage?
It will be a prolonged first stage.
So how would you plan? So what are the effects of the first stage of labor? As an anesthesiologist.
To reduce the pain, sir.
Pain. So for labor contraction pains is the first culprit, which is going to cause a tachycardia. So tachycardia is the worst enemy for a patient with mitral stenosis. So how to control the tachycardia in the early stages of first stage of labor and the middle or late stages of first stage of labor?
I'll go for an epidural.
Right from the beginning, as soon as the patient starts the early contractions, or it will wait for some time and go for epidural later. Normally, what is the the guideline for labor analgesia? Do you go for epidural right at the very first?
Usually in the second stage of labor to cut down the period of.
Second stage is actually
full dilatation.
Second stage is full dilatation to delivery of the fetus. First stage is onset of labor contractions to full dilatation of the cervix. That is the first stage. So that may take several hours.
At which dilatation you will give? That's all.
Cervical dilatation 3 centimeters, more than 3.
Yes, 3 centimeters.
3 to 4, yeah. After 3 to 4 only, you are supposed to go for epidural. Till that time, what is the best method? Normally, what are the pethidine? Will it, Pithidine good for mitral stenosis?
Tachycardia, it causes tachycardia.
It is a tachycardia. It is a, why it causes tachycardia? Why it is
Anticholinergic action. It has
not
similar
anticholinergic.
anticholinergic properties.
It has a structural similarity to atropine. Okay, so that is why it causes tachycardia. So that is not the ideal drug. Then, can you give Entonox?
Yes.
Yes, sir.
Yes, sir.
In case if the pulmonary hypertension is not there,
Always
No, this
be careful. Whenever a question is asked, there is always a catch in that. Okay, Entonox is not the ideal agent for a patient with mitral stenosis with a who will invariably have a pulmonary hypertension. Okay, so that is not the ideal drug also. So can you give CVOX?
CVOX.
CVOX can be given. Okay,
yes,
sevoflurane with oxygen
with
can be
oxygen.
given. Yeah. So, but here in the mitral stenosis patient, you can go for epidural right at the beginning itself. Okay, that is here because we don't want to interfere in some other way to control the pain. It is better to go for epidural at the very early stages of labor itself, so that we can nicely control the heart rate, which is a very important thing to do. Okay, and then so this is with regard to first stage of labor. Second stage.
Shorten the duration of the second stage of labor by using either
Outlet forceps or
outlet forceps or a vacuum.
Yes. So that is the
Assisted
second
delivery.
guideline that you have to say. That is second stage of labor should be reduced to that bare possible minimum time with assistance either by outlet forceps or vacuum suction. Okay, right. That is. What about the third stage?
Once the baby is delivered, rapid infusion of oxytocin should be avoided. Slow infusion to be used. Then ergometrin, methyl ergometrin, methogen should not be used, contraindicated in these cases.
First, better say what should be done before saying what should not be done. Especially in your patient, where she is breathless even in mild exertion, which
prevent the delayed clamping of the clot to prevent prevent autotransfusion.
Delayed clamping of the.
To prevent the delayed clamping.
Anyway, after the placenta is taken out, the uterus is going to contract, and the minimum 500 ml is going to go in. However much you delay clamping.
IV diuretics like frozen.
That is the most important thing. That is the most important. Anticipate that auto transfusion and give 20 milligrams of Lasix well before delivering or clamping the umbilical cord. Okay, that is the most important precautionary thing you have to take. So this is how you classify. First stage, early epidural. Second stage, cut down the the period of second stage by instrumentation. Third stage, prophylactic diuretic therapy and judicious use of IV fluids. You should not rush too much of IC fluid because there is some bleeding happening and all that. You can always hold on to the fluids very slowly and also give diuretics to anticipate this extra load that is going to come, especially with severe tight mitral stenosis, to prevent again a pulmonary edema happening because of the autotransfusion. Okay, so these are all the things. With regard to operative delivery, supposing you want to deliver by cesarean section, what is the best method of anesthetizing this patient?
That is based on certain factors, sir, whether it's mild, moderate, or severe mitral stenosis.
Okay.
And there is no specific regional, there is no specific anesthetic choice. The basis is maintaining hemodynamics. That is, any method which is going to maintain the hemodynamics would be the ideal method. Since in this case it's a mild to moderate, my plan is to go for an epidural anesthesia, provided the bleeding coagulation profile as well as the platelet count are within normal limits, and there is an adequate time period between the last dose of anticoagulation is present.
So you will stick only to epidural, titrated epidural. Any other option?
General anesthesia with
Any other,
anesthesia
any other neuroaxial, safe neuroaxial?
combined spinal epidural, sir.
That is another recent method which is very quite considered quite safe, isn't it? So for the sake of those who have not had the opportunity of doing combined spinal epidural, how do you do that?
It is a kit which has both an epidural needle as well as a spinal needle. First, we have to, as a routine for an epidural, injection, we have to locate the epidural space.
Yes.
Then through that, we'll be inserting another 27 gauge spinal needle through that, and we'll give the drug, and we have to thread the catheter.
So how much of drug you give through the longer spinal needle subarachnoid space?
A very low volume of spinal, like
see, if you are going to practically deal with the case, you must you cannot say very low volume and all that. You must say exactly how much I will give, isn't it?
0.5% of 0.5% of
bupivacaine heavy.
hyperbaric bupivacaine of 5 mg, sir. 5 mg.
That is 1 ml.
1 ml.
Volume wise, it is 1 ml. Okay, right. Supposing the level is not adequate, how will you manage that?
I'll top up with the epidural.
You give
So what is that?
fentanyl.
What is the
Spinal.
idea of doing this combined spinal epidural?
We can give a low volume of spinal drug to prevent the rapid sympatholytic effect, and we can, in case if it's inadequate, we can supplement with epidural, which is not going to cause a drastic fall in BP. So it gives us some breathing space to improve the BP.
Okay. At the same time, it also helps in the immediate onset of the block because you are injecting the drug into the subarachnoid space. Okay. So is there any other modern newer development which is taking place or which is now advocated to hasten the onset of block but without injecting the drug? The same method, but you are doing this because the epidural may take a little time to act, isn't it? Normally, when you give an epidural alone, you don't expect it to act as quickly as a subarachnoid block. You have to wait and see whether all the segments are adequately blocked, and then only patient will agree to be operated. But in order to hasten the epidural onset, what is the newer method that is being advocated?
Dural
Dural
puncture
puncture epidural. Have you heard of dural puncture epidural? Where you would first identify the epidural space as you do in a combined spinal epidural. Then you just deliberately puncture the dura with a spinal needle, 27 gauge. But don't inject any drug. Take out that and thread your catheter and then start giving your epidural dose straight away. Okay, so in a combined spinal epidural, you are identifying the subarachnoid space, seeing the CSF coming, and then you inject 1 ml or 0.75 ml of bupivacaine, and then thread the catheter and then give the top-up dose if never required. This is called combined spinal epidural method. Whereas the dural puncture epidural is you identify the epidural space, deliberately puncture the dura, see the CSF, but don't inject any drug. Take out the catheter, take out the needle, thread your catheter, and then start giving this. The idea is through the small hole that you have created, the epidural drug slowly seeps into the subarachnoid space, and the onset of anesthesia is faster compared to the simple straight epidural given with the drug loaded only in the epidural space. Okay, that has been a most recent advancement that has been done. So it is called dural puncture epidural to increase the onset of the epidural anesthesia without causing much of hypotension, without waiting too long for the epidural to act also. Okay, so you have three choices: a solo titrated catheter based epidural, Second is combined spinal epidural, where you inject the drug into the subarachnoid as well as thread the catheter and maintain anesthesia, which can be used for postoperative pain relief also. And the third technique is dural puncture epidural, where you just puncture the dura, don't give any drug, thread the catheter, start giving the epidural dose, maintain the anesthesia, and use the same thing for postoperative pain relief also. So these are the three things which have been considered safer methods rather than a single shot spinal with a heavy volume or a higher volume that you normally practice should not be done. And even when you are combining injecting the drug with a combined spinal epidural, better to make it with a opioid combination with a lower volume of local anesthetic rather than going in for a solo local anesthetic like 0.5% heavy bupivacaine alone. Okay, so that is how you manage if you do that, you can achieve a block up to say T10, which is more than sufficient to block the pain fibers, but the fundal pressure can be tolerated with the fentanyl or other opioid that you add to that without causing a block up to T4 and T5 and block all the sympathetic segments. So that is the advantage that you have. When it comes to general anesthesia, for some reason you have a contraindication for this central neuraxial blockade and you want to go for a general anesthesia, what precautions you have to take?
Aspiration prophylaxis, sir.
Okay, that is routine for all pregnant women. With regard to mitral stenosis, what are the goals in the management of anesthesia? General anesthesia.
Maintaining normal sinus rhythm, maintaining heart rate, avoiding tachycardia, maintaining a normal heart rate between 70 to 80 per minute, maintaining adequate preload, prevent reduction in the afterload, avoid factors increasing the pulmonary vascular resistance, and also avoid factors decreasing the systemic vascular resistance. And maintain adequate contractility and adequate oxygenation.
So I always remember that by the mnemonic PACRRI. PACRRI. P for preload, A for afterload, C for contractility, R for rate, R for rhythm, I for ischemia prevention. So this is what is given in the old textbook of Barash. These 6 points, if you keep in mind for all cardiovascular problem, whether it is ischemic heart disease or valvular heart disease or congenital heart diseases like AST, VST, any cardiac problem, if you remember these 6 points, you will be able to maintain a normal function of the cardiovascular system. So preload, afterload, contractility, rate, rhythm, and ischemia prevention. These are all the things that you have to keep. So preload should be very, very optimal. You cannot overload like you do in a regular pregnancy patient. So optimal preload, because this left side obstruction is preload dependent. So that you cannot decrease it too much, especially if the patient has been given a lot of diuretic in the preoperative phase to prevent the pulmonary congestion, then they may be hypovolemic. So in that stage, an induction may cause a sudden crash also. So you have to be very judicious in maintaining euvolemic state or optimal volemia preoperatively as a preload. Afterload should be mildly reduced so that the strain on the left ventricle will be less. And contractility should be preserved without suppression. Rate should be slow, slow, slow. That is what is given in Barash if you see. So mitral stenosis patient should have an ideal pulse rate between 60 to 70 is the ideal pulse rate to maintain intraoperatively, and avoid any arrhythmias like atrial fibrillation, and adequate oxygenation and correction of any anemia to prevent myocardial ischemia. See, these are all the points that you have to keep in mind. So with this goal in mind, what is the practical method of anesthetizing or giving GA for a mitral stenosis patient? What are all the safe drugs that you can use?
Avoid excessive pre-medication like sedatives, which might cause hypoxemia.
So pregnancy cesarean, you normally give any pre-medication except for acid aspiration prophylaxis?
No, sir. But
Mm. So it is not like a routine patient, isn't it? So whether it is elective or emergency, you give only acid aspiration prophylaxis as the main thing. Then you go for straight management on the table. Patient is on the table, all monitors connected. How are you going to proceed?
What is the
adequate
induction agent?
induction agent would be ethomidate, sir. Ethomidate, madam.
Straight away induction.
No, pre-oxygenation.
Pre-oxygenation with adequate pre-oxygenation.
See, this is how the exams, they may suddenly, when they say on the table, you have to go whatever steps you follow in your OT. Okay. So if they ask you generally, how do you manage, then you can go with saying what drugs you use and all that. But if they say patient is on OT table connected to all the monitors, then you have to go step by step as what you rightly do in the theater. If there is an IV line, okay, otherwise I will start an IV line.
Okay.
I will pre-oxygenate the patient, then I will go for rapid sequence induction using the following drug. These are all the answers that are expected out of you. Okay, go ahead.
I'll avoid opioids at the beginning. Then my induction agent of choice would be ethomidate. 0.2 mg per kg would be the dose of ethomidate. Then followed by a rapid sequence induction with succinylcholine 1 to 2 mg per kg. Or if there is any contraindication for succinylcholine, I'll use rocuronium for rapid sequence induction at the dose of 0.9 mg per kg. I'll use a smaller size ET tube of 6.5 millimeter as the chances of edema.
You said your patient has a short neck and it is an anticipated difficult airway. What other preparations you will do?
By using elevated, I'll use 2 or 3 pillows under the shoulder to
she's not
aid
a
in
obese
intubation.
patient. She is not according to your description, we are not talking about obesity here. You said she has a very short neck, environmental distance is narrow. So in that case,
Difficult airway cuts.
difficult airway card should be ready. More than that, what is the first answer? If the examiner tells you about an anticipated difficult airway, what is the first answer expected out of the candidate?
Brown.
Keep a good help, okay? An experienced person or a knowledgeable person to help you in a difficult situation. Okay? That is the first and foremost requisite. Then you have to think of managing the airway either awake or after induction. This is the second point that has to be decided. So if you anticipate a really very difficult airway like a patient, supposing you say short neck and the patient has got features of say Peary-Robin syndrome and you do a trialscopy, you are not able to see anything, any part of your epiglottis or more than the anterior 2/3 of the tongue, then you can go for awake intubation with fiber optic. That can be planned well in advance to avoid any catastrophe. On the contrary, if you are fairly confident that somehow you can manage after induction, then you have to have a good assistance. And the more common thing that if you go for intravenous induction with attempted intubation after relaxation, what are all the modern techniques of avoiding hypoxia or prolonging the safe apnea period?
Apneic oxygenation, sir. Using
Like what? Go step by step. There now everything is now given in a sequential fashion. How to avoid hypoxia in an anticipated difficult airway case is all mentioned in the books in the difficult airway guidelines in a sequential fashion. That is what is expected.
Adequate pre-oxygenation for 10 minutes.
Hmm.
Then non-invasive, CPAP,
Hmm.
continuous positive airway pressure through a tight-fitting mask.
Hmm.
Apneic oxygenation with the help of a high-frequency nasal cannula, HFNC machine.
Hmm.
Jet ventilation.
Jet ventilation. Hmm. So there is something called no DSAT, then something called Thrive. Before that, the simplest method that has been, see, originally what we used to do is we used to pre-oxygenate the patient for say 5 minutes or 8 vital capacity breaths. And then what you do, meanwhile, somebody will be giving the induction agent, somebody will give or the same person will give the relaxant. And once the patient loses consciousness, the assistant will apply Sellick's maneuver and pressurize the trachea. And you take off the mask and then put your scope after the fasciculations have stopped if it is hexamethonium, or waiting for adequate period if it is rocuronium. See whether you are able to see the cords and then intubate. This is the rapid sequence that was going on in the earlier method. So if you have any difficulty and if you are not able to pass the tube, time is going to run faster and the patient is going to start desaturating, because all the oxygen that you have given during the pre-oxygenation is utilized. So now the idea was to prevent this desaturation and prolong the safe apnea period as much as possible. So what was the first alteration or mechanism that was tried? They put in a nasal cannula, and through the nasal cannula they gave 15 liters of oxygen. Because in a conscious patient you cannot give 15 liters. Why?
It will be highly irritating.
Highly irritating and dry, it will cause mucosal damage also. Okay, so whereas in the unconscious patient, after induction you can put in the cannula and give a high flow oxygen, which is supposed to, what is the mechanism of apneic oxygenation? How does it help in oxygenating the patient?
It is by the formation of based on cardiac oscillation as well as formation of a supraglottic vortex.
You are confusing between high flow nasal oxygen and this 15 liters of oxygen. Both are not same. In 15 liters oxygen, you don't get all this vortex and the other things. So there the mechanism was 250 ml of oxygen is utilized or taken from the alveoli per minute. Isn't it? At the same time, only 10 ml of carbon dioxide is getting excreted from the blood into the alveoli. Okay? So there is a negative pressure created there. 250 ml of oxygen in the alveoli is going into the bloodstream, whereas only 10 ml of carbon dioxide is diffusing out because there is no active expiration. This negative pressure, 250 ml going in, only 10 ml coming, so 240 ml vacuum is there. So this causes, and there is a continuous flow of 15 liters of oxygen from the nasopharynx. So this pushes the oxygen towards the alveoli for further absorption. So what results in this is oxygenation is maintained as long as the oxygen is flowing in 15 liters, whereas the carbon dioxide is not getting eliminated actively because of absence of active expiration. So there is gradual increase in the CO2 level. CO2 buildup will be there. So beyond a particular point, the patient cannot tolerate this CO2 accumulation in the blood. They will go in for hypercarbia. That will cause stimulation of the heart and increase the blood pressure, increase the heart rate, all these things will happen. This is the mechanism of apneic oxygenation. But when they converted this into high flow nasal oxygen, where they started giving 30 liters up to a maximum of 70 liters per minute, which was humidified and heated by using the appropriate equipment, then what happened was all the things that you said there, it created a big flow of oxygen and washed out all the air from the anatomical dead space, and also had a force like a CPAP effect. And with the counter pulsation from the heart, it almost like a normal ventilation. So it resulted in both oxygenation and elimination of carbon dioxide. So the rise of CO2 was very, very slow in this HFNO technique using high flows of 30 to 70 liters. And especially that is why the name, if you give only 30 liters, it is called HFNO. If you go for 60, 70 liters, where elimination of carbon dioxide is much more compared to at 30 liters, it was called Thrive, because it is called ventilatory exchange. You are not only oxygenating, but you are removing the carbon dioxide also. Okay, so that is the basic difference between HFNO and Thrive. HFNO, still there is CO2 accumulation, but at a little slower, rapid rate. Whereas in Thrive, you have a very slow accumulation of CO2 with adequate oxygenation. And they have done even tubeless surgeries like microlaryngeal surgeries for 45 minutes, 50 minutes without any hypercarbic effects on the patient. Okay, so these are all the things that are being used nowadays to prevent hypoxia during difficult anticipated intubation, which may be suddenly asked. So you have to know all these points, right? So, so you have your induction agent of choice is etomidate. Your relaxant of choice is either Saxa or Rocuronium. Then how are you going to maintain anesthesia? GA.
And to prevent the intubation response, I will use IV Loxicard, 1.5 mg per kg, or Lebetalol 5 to 10 mg to blunt the intubation response. And the maintenance of anesthesia is with oxygen and sevoflurane less than 1 Mac. Oxygen with air or plain oxygen with sevoflurane, and muscle relaxation to maintenance of muscle relaxation with either cisatracurium or atracurium.
What is induction delivery time and what is its importance?
If you had listened to the previous classes, 1 minute, 1 minute, if you had listened to the previous classes, same thing, HFNO, Thrive, and the same, the whole thing was explained by sir. So please repeat it.
Usually 5 minutes, sir.
It should be 3 to 5 minutes, yeah. So that all the infection drugs don't cross the placenta and go and affect the Apgar score of the fetus. Okay, right. So that is why always the physician will be painting and drape the patient and kept ready
Before
with the DA. So that is a common question that you have to be aware of, right? Okay. So what are all the intraoperative precautions to be taken in a mitral stenosis patient?
Once again, the same goals of anesthesia as mentioned before, like maintaining preload, afterload, contractility, rate, rhythm, and adequate
What is the
oxygenation.
most important intraoperative challenge? Pain. How are you going to manage the pain? Normally, do you give any opioids for pain relief before the baby is delivered?
No, sir. No, sir.
So that period of 3 to 5 minutes is very crucial. How are you going to manage that?
Sir, 1 minute, sir. Sir, 1 minute. Nowadays, fentanyl is accepted, sir. Use of fentanyl even at induction, especially if a patient has a valvular heart disease, is accepted. Only we need to tell the pediatrician that
the drug has been used.
It is accepted, sir. It's accepted.
Okay. And naloxone has to be kept ready, sir.
Okay.
If fentanyl is being used.
Right.
IV infusion of paracetamol before the skin incision, sir.
IV infusion of paracetamol before skin incision. Okay. Yesterday there was a webinar on acute pain management. Did any of you listen to that? Marvelous medicine. by Dr. Vidya Mohanram. No time to listen to all those things. Okay. Right. So you can give fentanyl, you can give paracetamol, then opioid sparing analgesia. What are the drugs that can be used safely for in opioid sparing, which is a common short note question in your theory paper also.
Dexmedetomidine.
Hmm.
Ketorolac.
Yes.
Ketorolac.
NSAIDs.
Lignocaine, which you are given for blunting the hemodynamic response to laryngoscopy and intubation. Does it have any role in analgesia?
Continuous infusion can be used.
Continuous infusion can be used. Magnesium sulfate also is nowadays recommended. Low dose ketamine also is recommended because it doesn't cause tachycardia and other effects like your regular dose of ketamine. So even in cardiac patients or neurosurgery patients, they are using ketamine in a low dose as an infusion. Okay. So this question may suddenly come. Opioid sparing anesthesia. That is a thing you have to be ready. And what are all the regional blocks or local anesthetic blocks that can be administered to supplement your analgesic?
Bilateral transverse abdominis plane block can be used, sir.
Very good. TAB block. Then?
Quadratus lumborum block.
Quadratus lumborum. More anteriorly.
Bilaterally. Anteriorly.
What is there in the anterior abdominal wall?
The rectus sheath block.
Rectus sheath block. Yes. So rectus sheath and tab blocks are very, very useful blocks which can be used as a supplemental methods to avoid too much of opioids in these patients. Okay. Right. What precautions you have to take during recovery in this patient?
Adequate reversal of muscle relaxant and maintaining good tidal volume respiration with oxygenation.
Can extubation also cause tachycardia and hypertension?
Extubation response, yes, sir.
Once again, yeah, that also you have to take care of. So, what are all the methods of avoiding the tachycardia and hypertension during extubation?
Once again, post-extubation response can be blunted with the use of IV Loxicard 1.5 mg per kg. Esmolol can be used post-delivery as 0.5 mg per kg. Esmolol can be used as a short-acting beta blocker.
Or your dexmedetomidine is a wonderful given before.
But chances, we have to be very careful of bradycardia.
Bradycardia, yeah, that you have
hypotension.
So these are the methods that you can follow for that. So this will more or less complete the patient with the diabetes. And now we have not talked about diabetes.
Intraoperative. Intraoperatively, I'll try to maintain the blood sugar around 100 milligrams per deciliter. And if it's less than 70, in the pre-operative period, I'll start her on infusion of 75 ml per hour of 5% dextrose. And if it's more than 125, IV infusion of regular insulin at 1 to 1.25 units per hour will be maintained. And every half an hour, blood sugar has to be monitored in the general intraoperative period of general anesthesia.
What other drug can be injected for acute hypoglycemia? Supposing blood sugar has dropped to
IV glucagon, sir.
Glucagon can be given. Okay, that should be available in all theaters where you deal with diabetes patients, especially the pregnant woman. Okay, so these are the points that you have to remember. Now going on to obesity.
So the antibiotic prophylaxis.
Infective endocarditis prophylaxis.
Prophylaxis, yes. For both, whether it's diabetes or whether it's mitral, antibiotic prophylaxis you will have to mention.
Okay.
That's something which we missed.
But nowadays, I think mitral stenosis per se, they don't recommend endocarditis prophylaxis because only if it is a
With,
prosthetic
with
valve.
pregnancy, yes, sir. With pregnancy, they give, sir.
Okay.
That's one thing. And what we do for the mitral itself. Suppose this patient is in the second trimester and she has a real problem and we need to do something about the mitral. So
Mitral
can we
valve.
go ahead and do a mitral, whether we'll do the surgery or whether we can do something else?
That depends upon the severity of the mitral stenosis, madam. If she presents in the early trimester, if it's going to be a severe mitral stenosis, either a percutaneous balloon valvuloplasty would be the ideal one, rather than going for a open or open commissionotomy.
In the first trimester, it cannot be done. But even balloon
In the second trimester, between 20 to 24 weeks would
second
be the
and
ideal.
third, it can be done. Yes, okay.
Supposing she needs an MVR. Already once mitral valvotomy has been attempted and re-stenosis has happened, and that is very severe, and the only solution is MVR, and she becomes pregnant, unfortunately, and goes to final term. She has acute dyspnea, all the features, and she needs MVR also urgently. Then what to do?
See, I mean, mitral valve replacement under cardiopulmonary bypass can be done, but with certain precautions, it has to be done, sir. With
No,
like
it has to be combined with a cesarean section. First, you do the cesarean, deliver the baby. That should be done in a very, very sophisticated center with all available facilities. So you can plan to combine both the surgeries. Cesarean delivery followed by MVR has been also been reported successfully done in patients. Even cardiac transplants have been done after cesarean delivery successfully. And another important thing what I was reading is supposing a patient who has had earlier a mitral valve replacement becomes pregnant. What are the challenges that you will face? With an artificial valve working well in situ, if she becomes pregnant and comes for labor, what are the challenges that you will face?
Details about the history of valve, whether it's a bioprosthetic or a mechanical.
Okay.
And details about the anticoagulation drug she is on.
So that is the major issue. Most of them will be on anticoagulation drugs. So you must know it's pre-gestational counseling is very, very important in this patient. That is the point that should be emphasized. So if any lady with a mitral valve prosthesis plans to have a baby, she must be counseled well about the possibilities of stopping or altering the anticoagulation therapy, which may have some effect on the fetus. Okay, so they should be convinced about these possibilities. And then, as we earlier saw, avoid warfarin if they are on that, which is the common drug which is normally given for anticoagulation in all these patients, and convert them into either unfractured heparin or even low molecular heparin. And after completion of the organogenesis, up to 20 weeks, you continue them on these two parenteral anticoagulation. Then switch over to warfarin till the final trimester. And again, in the final trimester, go for the heparins. And all the time monitor the coagulation profile because they are basically in a hypercoagulable state during pregnancy. So we should neither jeopardize the functioning of the valve nor cause any excessive bleeding. So it should be a very, very judicious administration. So nowadays we have one excellent point of care testing. What is that? Thromboelastogram. So that should be utilized to the maximum, and ideal coagulation level should be maintained, or anticoagulant level should be maintained to make the balance the functioning of the valve as well as preventing any excessive bleeding happening in the patient. Okay, so that is the, and of course, being a prosthetic valve, endocarditis prophylaxis is also a must in all these cases. These are the 2 points that you should remember with regard to the prosthetic valve patient becoming pregnant and coming up to delivery stage. Now
Sir, I
coming
have
to, yeah,
I have two doubts, sir. A
uh,
mild to moderate case, if coming for an emergency section, what we have to do? Because
if they
starting
have effort tolerance is good, and if they have had no history of paroxysmal nocturnal dyspnea, you can safely go for your regular regional technique with a lower volume with combined with a opioid. Okay, so make sure that they have never had any, even one episode of paroxysmal nocturnal dyspnea is an indication that she is a decompensated patient. That has been the teaching right from my undergraduate days. On the contrary, if her effort tolerance is good, many of them become or come to know that they have a problem only when they become pregnant. And during a routine auscultation only, they have find out that she has a valvular pathology. So in such patients who have a good compensatory normal function of the heart without any pulmonary hypertension, so a quick echo will reveal the pulmonary pressures and the left atrial size. If they are all normal and the valve size is only about say mild to moderately contracted, there is no problem. You can go ahead with your regular method of anesthesia. Okay. Right. So coming to the obesity problem, what are the combination of things that will happen in obesity?
A difficult IV access, sir.
Mm.
Then positioning has to be very careful, preventing nerve compressions and difficult
No.
airway.
First of all, the common problem. See, in an obese patient, this pregnancy is going to cause, first think of the physiological changes that happen in pregnancy and see what will be that effect on the obesity problem. So cardiac wise, respiratory wise, renal wise, hepatic wise, then endocrine wise, like that. If you see what are all the involvements that happen in the pregnancy and combine or try to see what that effect will be on the obesity patient, then you will be able to answer them well.
With cardiovascular point wise, our blood pressure, obese patients generally have a higher blood pressure
They
values.
have higher blood pressure or hypertension tendency. Ischemic heart disease also is very common in that. So you have to first make sure that their pressures are, whereas a normal pregnancy woman may not have such hypertension. Whereas a combined obese and a pregnant patient, the blood pressure may be high, which should not be mistaken for a preeclampsia. That is the confusion that will happen. So you should not mistake that hypertension, which, so you have to find out whether she had any hypertension history prior to becoming pregnant because of obesity and whether she was on any medications. If so, what medications you have to alter. Once you know that the patient is hypertensive even before pregnancy, like a chronic hypertension becoming pregnant with obesity, what
AC and beta to be.
AC and
ARBs to be avoided.
AC ARBs have to be stopped and you have to switch over to some other antihypertensive because they can teratogenic.
IUGR.
Yeah, so you have to switch over to the other drugs. That is one problem. So rule out any ischemic heart disease also because of obesity. They can have associated silent ischemic changes. So that also has to be taken care of. Then coming to the respiratory system, already pregnancy causes a reduction in FRC.
Decrease FRC.
Pregnancy also is one of the causes. So what are all the common causes for reduction in FRC?
Obesity, obesity, pregnancy, pediatric population.
So again, I remember that by the mnemonic pangos, just like bongos is a drum which you use pangos, P-A-N-G-O-S. P for pregnancy, A for ascites, N for neonate, G for GA, O for obesity. S for surgery, especially upper abdominal surgery. PANGOS, PANGOS. P for pregnancy, A for ascites, N for neonate, G for GA, and O for obesity, S for surgery in the upper abdomen. All these things cause a reduction in the FRC. Okay, so this will be a double whammy. Both pregnancy itself reduces FRC and obesity also reduces FRC. So if you are planning for any procedure or any interventional surgical procedure, these patients should compulsorily always have oxygen supplementation. Not only pre-oxygenation, but even during normal labor and if you plan for a vaginal delivery also, they should be positioned comfortably and they should be given continuous oxygen supplementation to prevent hypoxia. Okay, that is a very important thing. And the obesity, as we saw in the class on this is an inflammatory state. So all the cytokines are released in excess and they are more prone for infection. So we have to
Hypercoagulable also.
hypercoagulable state is also there. DVT and prophylaxis should be there. And airway assessment and management should be planned well in advance. Okay? So these are the things that you have to keep in mind with regard to, and of course they may have associated diabetes also. Pregnancy is commonly associated with diabetes and other endocrine system involvement like thyroid, which is also one of the common causes for obesity, hypothyroidism. That also should be checked and ruled out. And Cushing's and other causes of obesity also should be thought of, other pathological causes, and all these things to be taken care of. Wasn't there anything else to add, Ma?
Cardiomyopathy, sir.
Cardiomyopathy in
Obesity, sir.
obesity.
Obesity with pregnancy. Obesity with pregnancy.
Okay. Nowadays, mostly all the physicians are very careful about even normal patients developing cardiomyopathy in the
Echo,
late final trimester. So they do
Yes,
an echo
Yes, sir.
before delivery as a routine, so that they don't land up with a sudden death postoperatively because of undetected cardiomyopathy. Okay, so that is one thing that has been going on. Right. So Kamachi, can I just share the screen for a minute?
Yes, please, sir. Yes, please, sir.
Sir, is
Sir,
there
one
any
doubt, sir.
Ah,
Sir,
fine, I got
what would be the normal INR to be maintained in the gestational period, sir, in case the patient is an unfractionate apparent?
and fraction apparent, usually we try to keep it 2 or 3 times if the patient is having any prosthetic valves, isn't it?
Okay, sir. Then since pregnancy is an hypercoagulable state, is it on the lower limit or 3 would be the...
Oh, it depends on the placental position and other features where it can result in unwanted bleeding. So if you think the patient is likely to have a bleeding episode, better to keep it on the lower side. Whereas if there is no threat, if it's a normally placed placenta with no chances of antepartum or intrapartum hemorrhage, then you can go for the higher side.
And regarding the use of cardiopulmonary bypass in case of an MVR done in the second or third trimester.
Second trimester, they don't advocate unless the only a limited intervention like balloon valvuloplasty or simple catheter techniques, depending upon the anatomy of the vessel. But if you want to go for a regular valve replacement, it is done ideally in the third trimester after the baby delivery only. You are not supposed to do any bypass during the second trimester.
Sir, is ropivacaine for ropivacaine? Ropivacaine.
Ropivacaine is less cardiotoxic, but the motor blockade is not that great. So unless you are it is
Not advised.
no, you can advise if your surgeon is very fast and they don't demand too much of relaxation, you can definitely use ropivacaine. There's no contraindication for that.
Okay.
Sir, can I ask one simple question, sir?
Ah.
So, in the initial pregnancy, you situate to heparin, and after 36 weeks, why you are again back again switching over to heparin? Why not continue with warfarin after 36 weeks? They said 5 milligram lesser you can use even in the first trimester, and subsequently you take up on warfarin, and after 36 weeks once back again to heparin.
Delivery can be at any time, sir. We are suspect of bleeding, actually, we are. And for regional technicals for the purpose.
Okay, and any other important reason with respect to the neonate?
Warfarin embryopathy is there, sir, but that is only during organogenesis period of warfarin is used.
So, which part has to come out during normal vaginal delivery with lot of stress strain?
Head.
Yeah. So, what is the risk of baby if you continue with warfarin?
Intracranial.
Yeah, somebody said correct.
Intracranial bleeding.
Yeah. So avoid intracranial hemorrhage for the baby. Sir, okay, we can go ahead with the presentation, sir. Sir.
Okay.
Thank you, Commander. Where did you read this? I didn't know this.
No, it is in the Bombay book, madam. It published long back.